Hi, my name is Rudy Pack, and I'm a third-year internal medicine resident at UT Austin, and my QI project is an initiative to eliminate low-value screening labs across the Central Texas VA. One of my faculty mentors, Dr. Moriades, was giving a lecture on high-value care, and when he was a resident at UCSF some many years ago, vitamin Ds were just being ordered left and right, and no one could tell him why. And I realize that this is still happening right now to this day at our VA, 2,000 miles away in Austin, a decade later. And so I decided that this would be the perfect time to figure out what's going on and get rid of these low-value labs. So for some background, low-value screening labs are bad, period. They're costly and happen to be very common at the VA. They waste time and resources. There's actual evidence that can cause real harm to the patient. At our clinic, every new or reestablishing patient, no matter who they are, receive a lab order set with these labs. We primarily focus on the vitamin D, albumin-creatinine ratio, TSH, and UA, because if you get the time to read these guidelines, there is no evidence that we should be screening with these labs. And in some, like the UA and TSH, they recommend avoiding it altogether. Our objective was to decrease these targeted labs by at least 50% during the academic year by eliminating them from the order set. For our methods, though the intervention occurred throughout Central Texas, our preliminary data is from the Primary Care Desk A within the AOPC, Austin Outpatient Clinic, from June 2022 to 23, and we trended the lab 6 months pre and post elimination. For the initial PDSA cycle, we actually met with the head pathologist from Temple who's in charge of the main lab to see if we could get their support. And they were on board since it would be less of a burden on them. Then we met with other stakeholders, including the medical director, admin, PCPs, and proposed the removal of vitamin D, TSH, and UA from the order set. We actually didn't focus on the albumin-creatinine ratio at the time, and we'll get into that later. There was some resistance, especially with the UA, but after some convincing, we removed them at the end of September 2022. We waited a couple months and thought it was just lag time, but realized that they were still being ordered. So we started investigating, met with the lead medical clerk in charge of the AMSAs, the Advanced Medical Support Assistants, and the head of eligibility because they were the ones who were ordering the labs. We realized there were two menus that were being used, the ambulatory menu and the one called CTX Medical Admin Services menu. The MSAs were ordering from the ambulatory, and eligibility was they were ordering from the CTX Medical Admin menu. We also noted that the albumin-creatinine ratio, ACR, was coupled with the UA, meaning that every time that the ACR was ordered, the UA was automatically ordered and done. After this, we met with the lead IT and finally removed all the targeted labs at the end of November while uncoupling the ACR UA early December. This is a graph trending lab orders from June 2022 to 23 with PDSA cycle 1 in red and PDSA cycle 2 in blue. The corresponding chart is below, and if you take a look at the lab orders from June 2022 and 23, the differences are pretty significant from 48% to 76% reduction of the labs. There was definitely a significant reduction in labs. I know that the previous slide showed 48 to 76% for those specific time points, but the 38 to 51% is from a 6-month average before and after intervention. The key takeaways from this project is that it's important to, number one, engage with stakeholders for support. We couldn't have done it without them, talking to the lab, admin, the clerks. Number two, it's also important to learn how your specific healthcare system works because this helped us realize why the initial intervention didn't work for us. And number three, our experience can provide a potential blueprint for other VA facilities who are trying to provide high-value care. And even though we, haven't completely eliminated the labs, this project really highlights the impact that systemic interventions can have. In conclusion, the large reductions that we've seen by eliminating these labs underscore the importance and potential impact of this strategy to decrease costs and provide high-value care. And that is my presentation. Thank you so much.